Right. Got it. Thank you. All right, Sam, you ready?
Yes, I am. All right, so Dr. Laura Drock is board certified in both pediatrics and hospice, as well as palliative care medicine. She received her Doctor of Osteopathic Medicine, or DO, from Nova Southeastern University. She completed her pediatric residency training through the University of South Florida. She was one of the founding members of the Pediatric Palliative Care team and Pediatric Palliative Care Champions program at All Children's Hospital. She is a division chief for the Pediatric Palliative Care team and serves as the program director for the Pediatric Hospice and Palliative Care Fellowship. Dr. Drock also serves on the Donor Advisory Committee, Physician Advisory Committee, Ethics Committee, and Advocacy Council at All Children's Hospital. Finally, she is actively involved in research and QI in her specialty field of hospice and palliative care medicine. So I will now pass it off to Dr. Drock.
Thank you, Sam, and thank you, Medical Explorers, for having me. I hope I can answer all your burning questions about medicine today. I also have some tidbits of information about other specialties that you might be involved in or interested in. And so the whole reason I do this is because when I was in high school, I came to visit this hospital and I had someone actually show me around, and that's how I got interested in this career. And so I think it's very important that we continue to educate everyone and let them know what kind of career that they could have in healthcare. So if you are not interested in being a physician or a nurse practitioner, which I'm going to talk about a little bit, if there's something else, feel free to reach out to me or Sam or Sarah or Angie. I know a lot of people because I've been at the hospital a long time, and I might be able to set you up with somebody if you have more questions. Okay, so with that, let's get started. Can you see my screen? Yes, perfect. Okay, so we are going to talk about pediatric palliative care for most of this presentation. However, like I said, I'm going to tell you a few other things that I've learned along the way as well. So let's see here. First things first. What can I tell you about myself? Well, I did it the long way. I was working at Domino's Pizza when I was in undergrad because it was a nice part-time job for some extra money. And then along the way, I became a home health aide because I knew I wanted to do healthcare and I needed to have a job. Then I became a certified nursing assistant. And then I went to Florida State University where I got my bachelor's degree in nursing. And while I was there, I was pretty sure that I wanted to be a nurse practitioner, although I still had medicine in the back of my mind. So after I did my nurse practitioner, I ended up going to medical school. And I have done lots of things, as you can see, throughout my career. So I took the long way. If you know what you want to do with your life, my advice to you is do it. You can do anything you put your mind to. I think that's important for me to say first and foremost. I think that if you are considering a career in medicine, you might be saying, oh my gosh, it's going to take so long. Well, you're going to be 25 one day anyway, or 30 years old one day anyway. Don't look at how much time it's going to take. Just do it because that's what you want to do. Okay, so that's my first set of advice. So what do you have to do if you want to be a physician? Well, the first thing is you have to have a bachelor's degree. So 4 years of college. So along the way, it's heavy science. So biology, chemistry, that's inorganic, organic, and then physics. And that's in addition to all the other classes you have to take. Just so in general, your English, your math, your sociology, your psychology, all of those. But again, you really have to show to the admissions committee that you have strong scores in biology, chemistry, and physics. And that does not mean that you have to have a biology degree, right? You can have a nursing degree, you can have a sociology degree, a psychology degree. I think lots of people go into college thinking, well, I have to have a science background or a science degree. You don't. But if you are going to be a sociology major or a psychology major, you still have to take these science classes. And that's why I have those on there. Okay. So after you take your MCAT and you've gotten great grades, the admissions committee at whatever university you decide to attend to, they'll admit you to their medical school, which is 4 years. Now, in the first 2 years of medical school, you pretty much will sit in a classroom and you will learn all of the things that you need to learn to be a physician. So you'll take classes such as physiology and anatomy and physiology and how to communicate with patients, hematology, oncology, OBGYN, pediatrics, all of these things for 2 years. And then after that, your second 2 years, you're going to the bedside. So you're going to be in a hospital setting or a clinic, and you're basically practicing what you've learned with people that are physicians. And when you're done with that, you basically in your last year, you're going to apply to a program called Residency. And when you apply to Residency, this is when you kind of have to know what you want to do. So you might want to be a pediatrician. You might want to be an internal medicine doctor. You might want to be a family doctor. You might want to be an orthopedist. There's lots of things to choose from. That usually takes 3 to 4 years. Now, I did pediatrics, so that was 3 years. So as you heard in my bio, I came to University of South Florida, and I did my 3 years of pediatrics training. So for 3 years, I basically worked in the hospital as a resident. I did get a salary for that. You get paid to do that. And I helped see patients. And so this is kind of how you get on your way. But again, if you don't want to do pediatrics, there's many, many things that you can choose from, but it just depends. The training depends on what you want to do. So if you want to be a surgeon, that may take 5 or 6 years, and you would want to apply to a surgical program. If you want to do orthopedics, the same thing. If you want to be an otolaryngologist, ENT, same thing. Okay, so it really just depends the field that you decide to go into. So moving on, who has heard of palliative care? Hands, or you guys are probably better than me with the thumbs up. Anyone? I see some of you, I'm scrolling through. Okay, so let me tell you a little bit about what palliative care is. So you might think, oh my gosh, she takes care of everybody that's dying. I do not take care of everybody that's dying. I take care of everybody that's living, because it's not about dying. It is about helping children and their families live to the fullest while they're facing these complex medical problems. It is the art and science of improving quality of life, attending to suffering, and assisting with medical decision-making for children with life-threatening conditions. Now, even though I'm a pediatrician and I practice palliative medicine, you can still use these same skills for adults. Now, maybe some of you have had grandparents or other family members that have died. That's hospice. Palliative care is having conversations around medical illness and serious medical conditions. So today on my list in my hospital, I have about 35 kids that I see and my whole team sees, because it is a team sport. And we'll talk a little bit about that later, but we're really wanting to make sure that people can make the right decisions for their lives. It's scary when you're in the hospital, right? And you might not feel well. So you might need some symptom management, which means that you're going to need medications to take away your pain or your nausea or your vomiting. It could be that you have a very, very strong Christian faith and you say, well, why did God do this to me, right? It could be that your parents are divorced and you're really struggling because mom and dad are each coming to the bedside and they're not getting along, and you need somebody to talk about with that. So that's the social worker. So that's why we have all different people on a palliative care team. So Maddie Stepanek is, unfortunately, he's already passed away, but he basically said that palliative care no longer means helping children die well. It means helping children and their families live well. And then when the time is certain, to help them die gently. Now, again, I have lots of kids that I take care of that they go on and they live very, very long lives. And I'll talk about some of those diagnoses in a minute. So although sometimes people confuse palliative care and hospice, maybe not so much you guys, but maybe some of your grandparents, because sometimes they say, oh, well, you have to have palliative radiation, which means that there's not a cure. Palliative care means that we are going to take care of your whole body and soul and medical conditions along the way. But sometimes we say it's the step before hospice, because unfortunately we don't have cures for everybody in this world, but we do everything we can to make sure that we're giving them all of the medication and all of the medical care that they need to try to get them to that place. So some of the patients that I see in the hospital are kids with cancer or cystic fibrosis, which fortunately cystic fibrosis, it's getting much more medical attention, and that people are surviving much longer with cystic fibrosis than they used to. I take care of a lot of premature babies, kids with cerebral palsy, which means that they really have a difficult time controlling their bodies, but the kids' minds are for the most part, they're very intelligent people. They just can't control their bodies well. Congenital diaphragmatic hernias, we have a whole program here for that. That's when you have a hole in your diaphragm. And so sometimes your belly contents will go up into your chest. And so we have children or babies that are born at Bayfront Baby Place, and then they come up to the 8th floor, which is where that unit is, and they see Dr. K's and they get a congenital diaphragmatic hernia repair. We take care of kids with sickle cell anemia. So that's a blood disorder where their red cells will sickle. And the sickle kind of looks like this, not round like a regular red blood cell. So they have a hard time getting oxygen to all their organs. And then we take care of kids with a lot of medical technologies, such as G-tubes and trachs. And I'm going to show you a picture of that. And that's just a sampling of some of the patients that I take care of in the hospital. So I don't know how many of you guys have seen these before, but in the slide on the left, you can see that's a tracheostomy tube. And sometimes we have to put that in when we have a blockage in the airway, or if a child needs long-term ventilation. So they need help breathing, okay? And then on the right side, that's a G-tube, and kids usually get that when they can't eat food by mouth. And so sometimes children that have cerebral palsy or they're premature infants, sometimes they have a difficult time eating. And so we have to put in a G-tube. Everybody is different. I never know what's going to happen, but many of our families, when they have these two types of medical technologies, that means that their children are pretty sick and they need an extra layer of support, which is where palliative care comes in. So some of the adult diseases that you might see if you're a palliative care doctor, again, cancer, multiple sclerosis, muscular dystrophy, chronic obstructive pulmonary disease that happens sometimes to people when they smoke a lot and they cause damage to their lungs. Alzheimer's disease, again, memory issues that just over the trajectory, these people cannot think or have a difficult time recognizing people. And then COVID-19 patients. We are actually seeing more kids with COVID-19 as well, but there are a lot of adults out there right now that really need help with COVID-19, either because they couldn't fight the disease very well and they have breathing issues. So we're seeing a lot of that, not in our hospital, but in the adult population. I hear a lot about this. So I'm going to show you a video briefly about palliative care and what it is and what it's not, just so you have a better idea. And hopefully it will work for us today. So let's see here.
Although end-of-life care can be a part of pediatric palliative care, it often is just a small part of what we do. Most of pediatric palliative care is integrated throughout the child's illness, and as a palliative care program, we take care of children often for many, many years, some of whom may eventually die of their disease and many who don't.
We need to make sure that children are well cared for. If a child is in pain and I'm entering a family's room, then the very first thing I need to do, I must be able to take this pain away right now. If I can do this, the child and the family will possibly trust me in helping them through the disease trajectory and making sure that as long as the strain takes, we are there to take care of pain, we are there to take care of distressing symptoms such as nausea, or vomiting, or diarrhea, and taking care of the siblings of the family and the primary care team.
Initially, when I was a nurse, and certainly even in the first few years of being a nurse practitioner, there was this idea that we tried to cure kids of their disease, and then if it didn't work and they weren't going to get better, then we did palliative care. There was no integration early on of kids with high-risk diseases or kids that we knew from the beginning might not survive their disease. And now I see that we change the way we do that. We incorporate quality of life, pain management, symptom management, all which are part of palliative care early on in treatment.
Palliative care is different than hospice care. I've known that hospice, it's got a stigma to it. It's basically, here's some opiates, you got to go to sleep, we'll keep you comfortable, and that's it, done. Palliative care is a whole different ball of wax. It's keeping the family as a family for as long as that can possibly happen.
I think it's really important to remember that we all have an opportunity to improve palliative care to all children throughout our institutions and whatever setting we work in, just by enhancing our knowledge and awareness and our sense of possibilities. and stepping up our skill sets just a little bit, we can ensure that children have access to better care. We provide an extra layer of support for families whose children have diseases that may take their life. They may not, and we hope with them that their children get better and recover. But over the course of serious illness, there are many things that palliative care providers can help with. Well, ideally, in a team, each person's voice has some importance, and we're able to talk about the medical needs, the psychosocial needs, the spiritual needs, the cultural context. We're able to have a dialogue on a regular basis. Healthcare moves fast, so it's hard to have these dialogues on a regular basis, but as best we can so that we understand the child and family in their context, and we're giving them enough time and space so that we can hear what they need. And what I see happening now, which is so wonderful as I look back on our experience, is that palliative care teams enter the picture at the very first point of diagnosis. So as you're riding that roller coaster of the ups and the downs, you've got a consistent support staff that gets to how your family functions in the good times and the bad times.
We in palliative care are often asked to help families, help children, where they may have a goal, but they don't know how to actually take steps towards it. And even if they have a sense of how they might be able to take steps towards it, they're very unsure as to whether they have the capacity to do it on their own. We bring that capacity to them. We give them ideas of how to achieve goals that they care about and actually help them accomplish them.
So we say in palliative care, and you might have seen some of the initials. There are a lot of different people that were in that video, right? So the last man that you saw is actually a very prominent researcher in our field. There are people that were at Harvard. That was Dr. Wolf. She's the very first person. Dr. Friedersdorf is actually at UCSF now in San Francisco. So there's a lot of people all over the United States that practice this type of medicine. But in some just basic principles about palliative care, we really are trying to focus on the family, and it's very relationship centered. So as in medicine, you want to have a good relationship with your patients. So we really focus on that because you have to know your patients to help them make decisions. We're not telling them the answer. We don't have the answer. Everybody on this call, you're all very different people. And I have a phrase that I tell to my parents. I say equally loving parents make different decisions, right? So just like you guys and your parents, some of you might decide one thing or something totally different. And well, what's a good example? Well, some of you might have extra money and you're like, I have to go to the theater. We love the theater, right? And other people might say, no, I want to go to the sports games. It's the same thing in medicine. Sometimes my patients are really, really sick and they won't recover to how they used to be. So I'm going to pick on a child that might have drowned. Okay. And when a child drowns, sometimes they can't walk or talk or feed themselves or do any of those things again. And I have parents that would say, okay, Dr. Drack, I need to take my child home. It doesn't matter how they live their life. I need them in home with me. And so when that happens, we put in a feeding tube because they can't eat anymore and they need a wheelchair and sometimes they need a breathing machine. And I have other parents that say, I don't want my child to live like that. Can you just make them comfortable? And we do that and we allow them a natural death. And that's why I say equally loving parents. Both sets of parents love their children more than you could ever imagine. I know you're not parents yet, right? And so they make decisions that they think how they would want their child to live. So a palliative care does a lot with that. So we are very goal-directed and consistent with the beliefs of the family. Again, it's not up to me. I have to help the families make the decisions that are best for their patient or for their child. Again, palliative care, it doesn't mean you're going to die. And basically what we're doing is we're making sure that parents are getting all of the information, especially when there's a lot of doctors involved, because a lot of the patients that I take care of, right, in the hospital, they might have the pulmonologist was the lung doctor, and the gastroenterologist was the GI doctor, and the critical care doctor who's running all the machines in the ICU, right? So when you have all of these doctors and they're all talking, sometimes it's hard for families to keep that all straight. So we help them keep that all straight and make sure that they understand everything that everyone has said. And so we're really advocating for our parents and their children. Every parent wants the best for their child. And we sit down with families and we let them talk it through with us. And when they ask us questions, we can say, well, I heard our pulmonology doctor, our lung doctor say that your child will feel better if they get this certain medicine every 6 hours, right? But the side effect is that they might have a high heart rate. So these are all the things that we kind of talk about. And sometimes with palliative care, children actually live longer because their symptoms are better. And we see that sometimes with kids that might have cancer that we can't cure, but if we can give them pain medicine, they have a better quality of life, or something like Ritalin, where they have more energy, we can help them live better lives. It's all about quality of life. This is my funny slide because this can be a serious topic. So we run around the hospital all day long and we ask children, how do you feel today? How do you feel today? How do you feel today? So the ones that can talk to me, we say, okay, pain scale 1 to 10. This is the improved pediatric score, where you can see all here at the end, hurts because your sibling just socked you in the stomach and totally faking. So I always think that this is funny and it makes me laugh. So let's talk a little bit about what we see in the United States. We know in the United States, in pediatrics, there's about 53,000 deaths a year of 0 to 19. And that's a hard number, I think, to really think about. In our field, we say that would be a big plane carrying children that crashes every 3 to 4 days. So that's a lot of families that need our help and a lot of children that need our help. And that's why this field is important. And on average at our hospital here in St. Petersburg, we see about 100 deaths a year. We don't want to see any children die, but again, we don't have cures for everyone yet. And we also have accidents that happen. Sometimes our babies are born too early and no one expected that. So again, we really are trying to help families on their journey. And this next slide is a slide of a child that has what's called a BiPAP mask in place. And so you can see this little tube and how it's attached to her nose. That's helping her breathe. And that's a type of technology that we use here in the hospital too. So as I said, when we got started, palliative care is kind of a team sport, and I work with everybody in the hospital, but on my team, we have physicians, nurse practitioners, social workers, child life specialists, psychologists, chaplains, occupational therapy, physical therapists, case managers, registered nurses. So we all work together because it really takes a village to take care of a child that has a lot of medical needs. And so again, if you're not interested in necessarily becoming a physician, there's lots of people that we need in the hospital. One of the things that I don't have on here as well is music therapy. I have people that are trained in music, and they walk around and they see children and they help them make songs, maybe sometimes to deal with their feelings of how difficult it is to be in the hospital. Sometimes we do what's called a heartbeat song, and we do those when they put like a stethoscope on the child's chest, and we record the heartbeat, and we can make a song out of that. So there's lots of cool things that we do in a children's hospital. So my role on the palliative care team, I'm obviously doing medicine, but part of that is understanding the child's disease process and how they got to where they are, because sometimes the child is just born. That's a little bit easier than a child that might come to the hospital when they're 12 years old. And we thought that maybe they were diagnosed with cancer when they were 5, and we thought that we were going to be able to cure them, but they come back to the hospital when they're 12 because they relapsed, okay? And then we're basically saying, okay, well, what can we do next to keep you healthy and comfortable and living your best life? Because sometimes those kids want to go to school, so we're helping set up school. Sometimes they want to make sure that they're going back out to play their favorite sport, whatever those are. And we help the family meet those goals. We address symptom management. So again, you heard a little bit about this earlier. There might be some pain. You might feel like you have to throw up, or you are throwing up. Maybe have a difficult time going to the bathroom, or sometimes you're really anxious, right? Like, who wouldn't be anxious if you were stuck in the hospital all the time? There's a lot of teenagers that I see, and they're oftentimes, thankfully, they're able to use technology now. So they're on their iPads or their phones, and they're talking to their friends. And I think that's wonderful because it helps keep them connected to the world. And you might have felt this way over the past 2 years with COVID-19, right? Maybe you had to do online school and you couldn't see your friends anymore. This is what happened for many, many years to the children in the hospital. So I love technology and we use it as much as we can. Facilitate team meetings. Sometimes we have to get all the doctors in a room and we talk to everyone to make sure that we're understanding all the information so families can make decisions. And sometimes we have to give bad news. Sometimes we have to say, we don't have a cure for your child. And that's really, really a difficult thing for physicians to say sometimes, because most people become doctors or nurses or nurse practitioners because they want to fix people and they want to cure people. That's what I love. I love it when we fix people and cure people. But again, sometimes that's not possible. And so then we have to say, you might be living with this disease for the rest of your life. Like if it's cystic fibrosis or asthma or diabetes, right? We don't have cures for all these things. We can help, but it's not curative therapy. Social workers, very, very important. They help our families with counseling. They help coordinate care, okay, and make sure that kids are getting maybe the health care that they need out in the community, or maybe it's the ventilators that they need out in the community. Sometimes it's working with people in our community. So we have a local hospice in St. Petersburg and Tampa and Clearwater. We call them and say, can you help take care of this patient at home? And again, it's not all death and dying. Sometimes it's palliative care. Sometimes they're helping in end-of-life decision-making. Sometimes we're making sure that we're following the cultural or religious beliefs. I have people from all walks of life in the hospital, Christians, Catholics, Buddhists. Sometimes people don't have a faith background and they're atheists and they say, okay, I don't want the chaplain. So all of those things, it helps us understand so we can help the family. Because if I do have a family that believes in something, I want to make sure we have resources for them. So in our hospital, we have a chapel. And sometimes families want to go to the chapel and they want to meditate or pray. So that's what the social worker kind of helps with. And then of course, coping. It is very difficult when you love your child so much that you have to come to the hospital all the time and take care of them. And there might be a brother and a sister to the patient who's now at home by themselves and who's helping care for them. So there's a lot that goes on when a child has to come to the hospital a lot. Child life. This is a great field. Usually you have to have a bachelor's or a master's degree to work in the hospital. But it's really, you might hear of this as play therapy, but it's oh so much more. Okay, so these are our people that are actually going to the bedside and they're playing with the kids. But when they're playing with the kids, they're really in a secret mission that it might be that they're saying, well, let's do art. And I've had lots of patients that draw art. And then you can ask them what they're thinking about. And sometimes they're drawing the hospital. Sometimes they draw what heaven looks like. Sometimes they draw what their future looks like. So it's very telling. A lot of times it's developmentally. Are we helping patients understand what they need to at their age? Because a 5-year-old isn't going to understand what a 10-year-old understands, what a 15-year-old understands, right? You're different developmentally. So I would never go in and talk to a 5-year-old like I would talk to a 15-year-old. A 15-year-old can make a lot of decisions, a 5-year-old cannot, but it's me explaining things to a child. And so we have puppets for them that the child life specialists use so they can explain things that are happening to their body. They also help the brothers and the sisters cope with what's happening. And then again, we help the whole family if we get to a point where we do need to do end of life. And then there's our chaplains. So they are basically doing questions of faith and what is your faith background and what does it mean to you? We already talked a little bit about that. Very, very important on our team. So you might have noticed that I am a DO and you're like, well, what is that? So when I became a nurse practitioner, we had DOs in the hospital and MDs in the hospital. And for me, I felt like the DO background was better for me and it was holistic. A lot of times people that end up in DO school already had previous life experience. And so it was just kind of like a different philosophy. It's a more holistic approach, but you still have to do all of the same classes and you still have to take all of the same tests. There is no special anything. I still had to take the MCAT. I still had to have all the same chemistry, biology, organic, all of it. Okay, so it's just a different philosophy. And there are becoming more and more DO schools out in the United States. So again, we already kind of went over this. You have to have a 4-year bachelor degree, 4 years of medical school, 3 years of residency, and then maybe a fellowship. Okay, so what is a fellowship? A fellowship is extra training after you complete that first year. So I became a pediatrician. Okay, it was 3 years. And then I wanted to specialize. and lots of my friends wanted to specialize. So if you want to be a neonatologist, so a baby doctor, after your general residency in pediatrics, you have to go to neonatology fellowship, which is 3 years. If you want to be a lung doctor, so somebody like a pulmonologist that takes care of asthma and cystic fibrosis, you have to do 3 years of a pulmonology fellowship. If you want to be a critical care doctor, it's 3 more years of a critical care specialist. Okay, so it just depends on what you want to do. Sports medicine, that's another popular field. That's 1 year after your general pediatrics training. So again, these are all the things that you have to think about when you're studying of what you like. And then you also have to think about what you want your life to look like, okay? Because if you work in an ICU environment, you're going to be spending the night at the hospital because there are sick kids in the hospital. Sports medicine, maybe not so much, but you might be spending a lot of time on the weekends at different sports games, okay? And if you love that, that's great, but you have to think a little bit about, what do I want my life to look like? Again, medical explorers, for those of you that want to be nurses, an RN is a registered nurse. There are lots of degrees out there for that. There's a 2-year nursing degree that's called an associate's degree. There's a 4-year degree called the bachelor's degree. And then if you want to go to nurse practitioner school, that's another 2 years. That's a master's in science of nursing. Okay. So that's another big field. We have a lot of nurse practitioners that work in the hospital with us. And I did it for a short period of time as well. So you still work very, very closely with the patients, and you still have to have a lot of knowledge to be able to do that kind of work. And you can, there's not really a specialized track. There can be, and you usually learn along the way. There are more fellowships out there. There's actually a palliative care fellowship for nurse practitioners up at Harvard right now. And so it's just different for everything that you decide to study. I talked about this a little bit, child life therapist and social work. You need to have a bachelor's degree in child life to work in the hospital, and usually a master's degree in social work. And last but not least, if you want to know a little bit more about palliative care, you can go to the Courageous Parents Network, or you can go to getpalliative.org. I like the Courageous Parents Network because it was made by parents for parents. So if you're like, oh, Dr. Drack, I want to learn a little bit more about G-tubes or tracheostomies, there's parents on there and then they actually talk about it. That's really good for the patients I take care of and their moms and dads, because they can go online and they can hear what another parent says. Because it's one thing to hear it from me as a physician, it's something else to hear it from a parent. So check out the websites. That is the end of my presentation on palliative care. But I want to take all your questions, and I hope we have enough time. I'll answer everything I can for you. Again, I want to tell you, wherever, you might say, oh, Dr. Drack, I don't know if I want to be a doctor. I don't know if I'm going to get into medical school. I don't know, I really struggle with math and science. You can do anything you put your mind to. I struggled with math when I was in high school, and I had to have a tutor. I'm still a physician, and I love what I do. So the world is for you. You can do whatever you want. It's just that you have to figure it out. And I think that's the hard part. All right, questions for you guys.
Thank you so much, Dr. Drack. That was informative, inspiring, and my brain is going. So thank you for sharing all of that, and the extra specialties as well was a good bonus. So explorers, feel free to type your questions in the chat, or don't be shy. You can also unmute yourself and ask a question live as well.
Come on.
Oh, sorry.
Oh, sorry. Yeah, go ahead.
What is like a day-to-day, like how does your day look generally?
That's a great question. So usually I get to the office at about 8 o'clock in the morning, and I have a very, very long list of patients that I start reading about because I want to know what happened the night before. So I read through and I see what everybody said. And then I sit down at a large table with all my colleagues and we start running through the list. Okay. So there's so many, you can't possibly know them all. So I have one of my other doctors. I have 3 doctors on my team and 2 nurse practitioners and a child life specialist and a social worker and a chaplain. So we all sit down and we talk about each of the patients. And somebody might say, well, Johnny had a really bad night. They had to start this new medication, or Johnny's going to go home today and we're very excited. And we need to make sure that they have all the supplies that they need at home. But we all talk for about an hour. And then after that, we start going out and we start seeing patients. So we go to each floor and we start meeting with families. We meet with the other doctors, we get updates. And sometimes we sit in the parents' rooms for maybe 30 minutes to an hour, depending on what's going on, unless it's something that's more symptom management. And then Johnny says, well, Dr. Drack, my knee hurts today, and can you please help me with my knee? And then we make sure that they're getting the right pain medication. And we usually do that all day long. Sometimes we have care conferences where we sit down with a lot of people. I actually just left the care conference right before I came here, where I had the critical care doctor and the nurse practitioner and my resident, as well as the mom. And we talked about care for her child, and her child is really, really sick right now. And something that is sometimes hard for parents to do is to think about things that they can do in the hospital. It's really scary when you see all of the machines and the tubes, and sometimes they're scared to touch their children. So we basically show them how to touch their child, and we actually help this mom get in bed with her child. So that made everybody feel good. So it just depends every day. Sometimes we run to emergencies. Sometimes if we have an end of life, we're helping families say goodbye to their children. That's hard, but it can be so rewarding, because it's so important that when we do have to say goodbye to our children, that we do everything we can to make sure that it goes as well as we can for that child, that they have a good death. This is for anybody that dies, right? You want people to die well. But that is not every day. It's usually not the rule, it's the exception. Okay, we're usually running around seeing patients and talking to kids and having a really good time doing it. It's very rewarding. Oh gosh, look at all these questions.
I was gonna say, I'll read them off to you if that's okay. How do you personally deal with the mental aspect of losing a patient? Speaking of.
That is a great question. You know, when I was a nurse, and I was a bedside nurse, and I worked in the pediatric intensive care unit, and I worked in the bone marrow transplant unit. These kids were really, really sick. Okay. And this was back in the 90s. And you guys probably weren't even on the planet yet, but I was. And we didn't talk about death and dying as much as we do now. It was something that nobody wanted to talk about. It was forbidden. And so for me, being able to talk to families about it and help them prepare for that makes me feel better, because there's nothing worse than not talking about it. And then when we go to our meeting every morning at 9 a.m., we talk about the hard things. Oh my gosh, that was so terrible yesterday. What happened to that family, and how are we going to move forward with that? And we know that since we helped that family, that's better than not helping them at all. And there was a day when we couldn't help them as much. We didn't talk about it. And I think it really helps to be able to talk to families and say, okay, this is how we're going to make it better for you. You know, let's make handprints. Let's cut lockets of hair. I had a family once that their child had died, and the mom said, oh my gosh, I really wish that Johnny would have been able to drive a car. And dad looks to the side and laughed and said, well, he did. Johnny was 15. He shouldn't have been driving the car. And mom said, what do you mean? And he's like, oh, I took Johnny to drive the car, right? So we help with these conversations. So as incredibly sad as it is, we have, if it's going to happen, we have to let it happen the best that we can to the best of our ability, if that makes sense.
Okay, thank you. That's good. How did you stay motivated to continue, especially with the change in careers?
I wanted to be a doctor. I just wanted to be a doctor so badly. And I studied a lot, and I was in the chemistry lab on the weekends. And it's just something that I was motivated to do. It has to be within inside you. You have to want it. It has to come within you. And you can do it if you want it. You can do it.
Yes, for sure. What are some recommended majors for undergrad when I don't know what a specialty I want? Great question.
Well, that is a great question. You know, I think this is really hard, even when you're in high school, right? You might not know the answers. I think if you have friends and there's something that you're like, well, I might be interested in that, find those people to talk to. Okay. It might be that and I don't know, you have parents that do certain things. You might be, hey, I know that your mom is a social worker. Can I talk to her? I know that your dad is an airline pilot. Can I talk to him? I know all of you are on here for medical explorers, but it might be that you just have to go to like something like this and hear different people talk to kind of try to figure that out. You have to find something that you think will fit to you. I know that we all have to take biology and chemistry, but there are some physicians that need chemistry, right? And maybe some not as much, all right? I'm not doing organic chemistry or inorganic chemistry every day in my office. I'm doing a lot of communication in those types of skills. So I think it's reaching out to people and thinking what you might, and maybe shadowing them for a day if you can. I know it's COVID right now, and I hope that goes away soon, but then coming to things like this, like Medical Explorers, that's really helpful.
Okay. Do any therapists participate in palliative care? This sounds very interesting, but I'm also interested in being a counseling psychologist.
Absolutely. I have a psychologist that works on my team, and the way the hospital is set up, there is a psychologist on every floor, but I work with all of them, right? I worked with one today. We had a patient that is very anxious because he has to wear a mask on his face to help him breathe. And that causes a lot of anxiety when you have this mask strapped on your face. And I'm not talking about these, right? The ones that we wear around the hospital now. I'm talking about one that helps him breathe. It's on his face very tight and it makes us anxious. So the psychologist talked to him a little bit about deep breathing and different strategies he can use to help overcome his anxiety. And sometimes it's medication, but sometimes it's having an understanding of how the mask works and those sorts of things. So yes, we use psychologists all the time.
And I didn't even know that we had psychologists on each floor. That's good to know. That's nice. You kind of touched on this, but how useful is chemistry for a pediatrician?
You know, when you are learning about pharmacology, right, sometimes that's very helpful. When you are learning about acid-base balance for ventilators, yes, it can be helpful. Are you using the chemistry that you learned in chemistry class in the hospital? Not as much, but it's still to understand the different elements and oxygen and CO2, those sorts of things. That's very important, especially if you're in a critical care setting, okay? And it might not be something that you're thinking about you're using all day long, right? Certainly there are several nurses that might not have to have taken the chemistries that you have to take as a physician. You still have to learn it. So it's totally doable. It's just a different level, right? Like chemistry, some of those things you'll never see, but the basic chemistry, yes, you will use it.
Okay. Always a good question. How do you balance your very demanding role at All Children's with your life outside of work?
That is a great question. You know, I think that right now it's been very difficult with COVID, but you have to figure out what brings you joy, peace, and happiness. Okay. And you have to be able to balance that. When I was younger and I didn't have children, I was all in. Oh, I want to be at the hospital. This is all I want to do. And I did. You live in the hospital. And now that I have children, I have a 10-year-old and a 14-year-old. I want to spend time with them. And so I make sure that I do everything I can to balance my priorities. And that's something that everybody that works in a hospital is constantly doing. And I'm sure your parents are doing the same thing, right? You have to figure out where your boundaries are, what you can say no to, and what brings you joy, right? Because maybe you go into medicine and they're like, well, do you want to be a researcher too? Not everybody wants to be a researcher, right? So you don't say yes to doing research. You find things that bring you joy and happiness, but that's a great question. And we all are dealing with this every day.
Always, yes. Did you work while in medical school?
I did not. I will tell you, medical school is a full-time job. I did have friends that did work. I was thankful that I had the resources to not have to work, but I will tell you that if you can work and still maintain your grades, that's smart, because there are other fields out there that are much more competitive than pediatrics, like surgery and plastic surgery, and you want to make sure that you can have the best grades that you can get to get into those programs, okay? Not that the rest of the subspecialties out there aren't hard, but there are some that are more difficult. So you want to make sure that you have the best grades that you can. Certainly, if you can get work experience along the way, that's always a bonus. And you don't want to have a lot of loans when you graduate from medical school. You can certainly do any type of the armed forces. You can do National Health Service Corps. They will pay your loans. I've worked at All Children's for 10 years. And after you work at a nonprofit for 10 years, like I did, they will pay off the rest of your loans. So you have to look into these things when you're going to medical school. Don't put your head in the sand. You're going to want to figure things out, okay? Because I know people out there that have student loans that are as much as their house. So you're paying 2 mortgages, right? So your medical school loans could be $400,000 if you're not careful. So you need to find out who you can live with, if you can live with your parents and go to a medical school close by, get scholarships, do everything you can to get your student loans as low as you can, because you don't want to when you're going to medical school, you think, I'm going to make all this money, but you don't want to pay the student loans off for the rest of your life. You're going to want to buy a house. You want to go on vacation. You might want to have a family. You have to think about those things.
Sure. Let's see, we kind of answered that one already. Does choosing a less typical major in college, like sociology, art, etc., make the individual stand out when applying to medical schools? Do you think?
I don't know that I can answer that. I think it depends what you want to do. If you are still taking your courses in biology, organic, inorganic, and you have good grades in those, I don't think, and your MCAT scores are good, I don't know that the admissions committee is really going to care whether you were biology, sociology, psychology, nutrition. There's a lot of physicians I work with, and they did not have a typical biology degree. I don't know if it makes you more or less attractive. I think, again, your grades and your life experience, certainly if you had factors that influenced you, maybe you did have a brother or sister with cancer. Maybe your parents were first-generation immigrants. Maybe you're first-generation immigrants. It's the total picture of who you are as a person. And just because one medical school that you had your heart set on doesn't accept you does not make you less valuable. If you want to be a doctor, you go where they take you because that's where you were meant to be. That's what I think. Okay. If you want to be, and the same with nursing school or physical therapy school or occupational school or pharmacy, right? You'll end up where you're meant to be.
I agree. Yes. Any other questions? These are great.
Music therapy. I see. Could you explain a little bit about music therapy? So that is a great field. You really have to understand, number one, music. Our music therapists usually play 2 or 3 different instruments, which is really, really cool. But they also need to understand how music affects the mind and the body. And again, from how do you talk to a teenager that might be dying or a parent that is losing their child and those sorts of things. So it is very a complex field, and there are a handful of music therapists out there. So I'm not sure, Catherine, I am happy to put you in touch with a music therapist, and Angie or Sam, somebody will be able to, I'll put my email address in here, but if you guys have any questions, you can send them to me. I'm going to put my email address in here right now. If you have questions, and if you want me to set you up with somebody that is not a doctor, or maybe you're like, oh, Dr. Doc, I really want to be a surgeon, I can put you in touch with people. Okay, so there's my email address. Okay, did you work while in med school? No. With the special connections that you make with patients, how do you cope with the loss of life? Sometimes I know what's going to happen, and I have to prepare myself, right? Because I get very, very fond of the kids I take care of. But I also know that I'm going to help them live their best life possible. And everybody has a beginning and an end. And it's all different across the board. I have babies that might die when they're, 3 months old, and then I help the parents. And then if I have a 20-year-old that's dying, I just help them have the best life possible. And I might cry and I might be sad. I hold it together when I'm with my patients. And then I go back and we talk to our families and we talk about all the wonderful things about that child, right? It was still a good life worth living, even if it was short. And sometimes these kids make such great impacts on all the world around them. Let's see here. Did you take the MCAT your junior or senior year? So remember, I'm not a traditional student. Okay. I went to nursing school first. And so I did things a little backwards. After I was done with nursing school, then I went to nurse practitioner school. And after I was done with nurse practitioner school, I went back and I had to take biology, organic chemistry, and physics. Okay. So I took that. I was still working as a nurse. Okay. I was a nurse still working a full-time job when I took those courses. Okay. So I believe that I ended up taking the MCAT then after I had finished those 2 years of courses, and then I just waited. I don't know what the average person does. I think that you take it when you feel like you're ready for it. Certainly a prep class. I don't know who out there does it now, but Kaplan can never hurt. You want to make sure that you're doing everything you can to get the best score possible, because medical school is competitive. How does school work for children in the hospital? Are we running? I know we're running out of time. So basically we have school teachers in the hospital. So they'll come in, and sometimes our kids are actually doing virtual classes online, depends on the state that you live in. But a lot of times kids are now able to join the class virtually from their classroom. Does the pediatric unit seem closer amongst themselves and with their patients because the patients are kids, or does it feel like a regular adult unit, if that makes sense? It does not feel like an adult unit. I've worked in adult hospitals. It is very, very different. I think that adult medicine and pediatric medicine are very, very different. Just in general, I wish the adult hospitals were as much fun and playful as the pediatric hospital, but it's a lot of fun to be in a kid hospital. We have a big, huge, giant playroom for the kids when we weren't in COVID land. It's a little not as used as it used to, but we have a pool table in there and a foosball table and a basketball court, and there's arts and crafts and a big TV. And we do like if you guys have been on a cruise, we have like bingo at the end of the day, and there's always something fun going on. At Christmas time, I celebrate Christmas, so I talk about Christmas. We make sure that parents get to do what's called a winter wonderland, and they go and they get to pick out gifts for their children. So everything is very, very child focused in a kid's hospital. You won't see that in an adult hospital. Yeah. How do you make decisions confidently, especially with such a wide range of patients? How do you know that what you're doing is right for the patient? You know, I work with a lot of smart people, right? And it's not unilateral. We're all talking all of the time, right? We have multiple years of experience when we're talking, and everybody has seen something different. So it could be that one of my critical care doctors says, Laura, Dr. Jack, I saw that 3 years ago, and this is what we did, and it worked like a charm. Okay, well, let's try it. Sometimes it's just standard. We know that's what works because this is what we learned in the textbook, and this is how we deal with it. So what am I talking about? I'm talking maybe a child that has diabetic ketoacidosis, right? And we know that those sugars are really high, and we need to put them on an insulin drip, and we need to give them fluids to get the sugars to come down. But a lot of times when it's difficult decisions, it's again, sitting with parents and giving them their options and saying, how do you want to see this happen? Could I get your email? Yes. So I put my email on there. I'll do it again so you guys can see it. I see there's more questions coming, but I know that it's 5:30 and I don't know.
I think some are direct messaging you. So maybe put the email in the everyone chat, if that makes sense.
Okay. Everyone. Thank you for saying that.
There we go. Because you were reading some questions that I wasn't seeing. And I was like, where are those questions?
Yeah.
Okay. Oh, there we go. Perfect. Everybody should be able to see that.
You guys ask awesome questions. I want you to know that. And I'm really proud that you're here. This is how I started my career in medicine. As I went to the hospital, we didn't have Zoom. We didn't have virtual. You just had to show up. Not aging myself. I'm probably, I could be some of your parents' age, maybe a little older, but in any event, go to the hospital, talk to people. When people love what they do, they want to tell you, we need people to take care of the old people like me. I need you guys to go into medicine, okay? You need to be doctors. I need you to take care of me when I get old. But it's a very rewarding career. I know you're seeing a lot of what's happening in the news right now with COVID. This is a scary time in our lives, especially for people that work in medicine. I've never seen anything like this. And I've seen a lot of stuff in my life. I've been in healthcare for 30 years, just in everything I've seen. When I was a brand new nurse, we started seeing MRSA, and that was kind of like COVID. That's when it first came out, and we didn't think we had medications to treat it, and it was very, very scary. And now MRSA is, well, it's MRSA, methicillin-resistant Staph aureus. Okay, so you will see things in your lifetime that are just incredible. Medicine is always changing. It's an art and it's a science.
It's true. Well, thanks. I think that's all we have time for today. Sarah, you have anything else to add or say?
I just want to say again, thank you, Dr. Drock, for that amazing presentation and information for us to take forward through our journey into medicine or wherever we end up. Thank you for sharing your wisdom and experience with us. Explorers, thank you for being here today. We are so excited we could mesh the two exploring hospitals in the Hopkins community. This is super exciting for us. And our next session together as a group will be on May 9th with Suburban Hospital. One of our specialties, cardiothoracic surgery. So we'll have our two surgeons here to talk about what they do, heart surgery, and their awesome experiences in that field. So without further ado, I think I will let everyone get back to their evening. Again, thank you for sharing your time and have a great evening.
Thanks, everybody.
Thank you, guys. Thank you, Dr.
Thanks,
Drock.
Sarah.
Thank you.
Thank you.
Thank you.